So first, we've talked a lot about these different studies. We've updated these studies a couple of times, but basically, CLL is in the US at least one of the most common lymphoid malignancy, and there's been tremendous progress in treating patients with different new agents, and in particular BTK inhibitors, and with Ibrutinib and acalabrutinib. But what we know is that in patients who fail this treatment, who progress or who don't respond well to this treatment, the prognosis is overall quite poor. And if we look at patients with high-risk features, in particular, very highly complex cytogenetics, we could see that it's very unlikely that we will achieve long-term responses and potentially cure in these patients. So we did a study using CD19 targeted CAR-T cells of defined composition in patients with relapsed refractory CLL, and in particular those who had progressed or did not respond to Ibrutinib. And what we did for a variety of reasons is that we thought it'd be a good idea to give them a drug, so to give them Ibrutinib concurrently with CAR-T cell therapy. So when we mean, what do we mean with concurrently? We mean that patients had to be on Ibrutinib for at least 2 weeks prior to cell collection, and then they had to continue on Ibrutinib all the way through lymphodepletion and for at least 3 months after the infusion of the CAR-T cells. And so what we think is interesting is that basically we saw that it was a very feasible approach. Patients tolerated well Ibrutinib during the treatment, and the key finding really is that despite that we measured significantly higher number of CAR-T cells in vivo in these patients, and also that we saw a trend with higher response rates, we actually observed lower toxicity in patients with Ibrutinib. And in particular, we saw lower toxicity of cytokine, lower severe CRS severity, so lower severity of cytokine release syndrome. So that's really the key finding from that study. And overall, we've seen very, very promising outcomes. And this was a pilot study, a retrospective analysis, and we need more data and more follow-up. But overall, when we combine patients who did not receive Ibrutinib and those who did receive Ibrutinib, the overall response rates was about 70% at 4 weeks, and the percentage of deep responses with no detectable disease by IGH sequencing was 74%. So that's to us is very encouraging. And overall, the 1 year overall survival and progression-free survival probabilities in these patients who did achieve deep response with 86 and 59% respectively. So the median PFS was not achieved. So these are very, very encouraging finding, and there are ongoing studies, in particular one that is carried out by Juno/Celgene/BMS, now called the Transcend CLL study, which is a multi-center study, and this study has one cohort with patients treated with concurrent Ibrutinib, and we hope these encouraging findings will be replicated